So hello, everyone. Welcome to this connected conversation on precision health. The Connected Conversations series is curated by UNICEF's Innovation Nodes team. And you might ask yourself, what are these? Well, UNICEF Innovation Nodes are transdisciplinary and collaborative spaces that focus on reflecting and generating novel wisdom in new and unknown areas of potential innovation for children. And precision health is an excellent example of what such an area could look like. UNICEF's global innovation strategy really asked us to identify gaps and opportunities to uncover unproven approaches and technologies that could be explored to benefit children, especially the most marginalized children around the world, which are, of course, the focus of UNICEF's work. So the nodes are really around inquiring and discovering these areas and unpacking and understanding what could they mean for children. So this connected conversation is a part of that, and we'll be sharing with you some resources in the chat. One of them is a foundational piece, and it really is this quite comprehensive report, an insight report around precision health and its potential for children, to benefit children in different ways. This area that is really an emerging piece of research with numerous emerging technologies that is going to come to affect all of our lives, whether we have access to it or not, over the next 3 to 10 years. So really encourage you to look to that for an in-depth unpacking of the space and a variety of different technologies that fall beneath it. But one area that we are really wanting to focus on in today's connected conversation with this fantastic panel of experts is, what does this new technology and what does these applications of this in access to this really mean in terms of health equity? Our panelists include Dr. Janice Limson, who is the South African Research Chair in Biotechnology, Innovation and Engagement, as well as being the Professor of Biotech and the Director of the Biotech Innovation Center at Rhodes University. Corin Cullender is the Senior Health Advisor and Chief of Digital Health and Information Systems at UNICEF. And Professor Stefan Swartling-Petersen is the Professor of Global Transformation for Health at the Karolinska Institutet in Sweden, as well as being the health specialist at UNICEF Sweden. So welcome to all of you and welcome to our panelists. I want to turn immediately to frame this entire area of work. For many of us, we're not quite sure what precision health might actually mean and be, or more than likely we've seen snippets of it in sort of science fiction sounding stories in the news. So in this first part of our conversation, I'd really like to start to establish a common understanding among us and dozens of people that I see have joined us around what are some of the key challenges that frontline health service delivery and frontline health workers face, and what something like precision health can promise and deliver in really kind of practical terms, so that we come out of this really understanding in this first question, what are we talking about? Because despite so many improvements in survival and nutrition of children over recent decades, still far too many of them suffer and die from preventable and treatable diseases. And our current model of healthcare is designed on the average patient and based on signs and symptoms. But achieving the Sustainable Development Goals will require a global shift from treating diseases in this way to really strengthening entire health systems, so that children and women of reproductive age can have healthcare access to affordable and accessible quality care. So to kick this discussion off, I'm turning first to you, Corin, to share your thoughts on frontline service delivery models, national health systems, and where you see a little bit of precision health actually fitting in. Over to you, Corin.
Sure. Thanks, Tanya. And glad to see some familiar names having joined this conversation online. And I just wanted to maybe start by talking about the average model that you're talking about today, that we have today, which seems to not really be reaching everybody. And obviously the number of challenges that hinder mothers of sick children to seek early care and appropriate diagnostics. There are multiple challenges. There are many types of challenges at different levels. And what we see is, of course, many of these challenges being aggravated by humanitarian crisis and fragile, especially in fragile contexts, and climate change, etc. And just to look at what we're talking about here, we know that access to quality primary health care, even on sort of primary healthcare facilities that are on the front line, is hampered by things still like geographical distances to the most remote communities, the most vulnerable communities, health workforce shortages, getting trained personnel to work in the remote facilities is still very, very tricky. Lack of appropriate functioning infrastructure in these facilities, security for patients who are seeking care, financial and logistical constraints to enable sort of consistent medical supply, as well as the health information systems needed to not only collect data for analytics, but also to forecast the needs and forecast sort of forthcoming events or epidemics or what it might be, and planning healthcare. So we've also, one really important challenge of our current system is the lack of attention to the social and cultural barriers for caregivers, which may also lead to these delays in healthcare that especially lead to easily treatable conditions leading to very severe to a severe stage before they're even seen at a frontline facility. And in my work, I've been involved a lot in developing a methodology around social autopsies, which were specifically designed to understand why children who die fall off this pathway to survival for even simple infections like diarrhea, malaria, pneumonia, which we know are easily treatable. And it often comes down to late care seeking, late recognition of these symptoms, leading to these children getting to the facilities when it's too late to intervene, or when facilities cannot really handle these severe cases at that level. And often also it comes down to decision-making and late decision-making because of lack of female empowerment, leading to women having to wait for the husbands to come home to take a decision on where and when to go for healthcare. So this all kind of comes down to why in UNICEF we really strongly advocate for the need for a health service delivery model that brings primary health care closer to the families and where they live, using trained and equipped and incentivized community health workers who can conduct a simple diagnosis and provide life-saving treatment, but also health education to families and help with establishing this trust and respect with community members, so that community members can be better at taking sort of informed health decisions about their families and their children. And this is where I believe there's a lot of room for more precision health techniques to better target not only where community health workers work, which communities should be prioritized, and what these community health workers should be equipped to do, and also which types of diagnostics specifically that they have in their portfolio to be able to conduct a diagnosis of a sick child.
Absolutely. And thank you for really bringing that to life and giving me my the first of, I'm sure, a number of favorite concepts from the session, social autopsies. I'm so glad you brought up the issue around time, and time really having a life, outcome meaning to it. And specifically talking to the point of diagnostics, because Janice, I think this really ties very closely to much of your research, which is focused on our understanding and designing for specific and localized needs in health systems and service delivery. I wonder, could you speak to some of these needs and the related sort of challenges that you see facing health systems today?
Thank you. And thank you, Karen, because I think you really framed that so beautifully, because this is definitely our experience. And even though I'm a scientist, we have started shifting the way we do research. We have found it best to actually engage with communities and establish what the localized needs and perspectives are. And so our recent experiences have certainly shown us this. People are separated from healthcare by rivers or mountains. And if they do manage to get to a clinic, the length of time it takes and multiple other challenges as well. And we do realize, I think, that if you wish to access precision health, we really need to focus on precision diagnostics. So considering all of what you've framed and the need for speed, and potentially giving a diagnosis at the time can obviously help to inform better treatment and treatment outcomes as well. And so our research has largely focused on developing rapid diagnostic tests. Our work has certainly been informed by fetal and maternal healthcare needs and children's needs. And in fact, some of our research with UNICEF has focused on developing better rapid diagnostic tests for a range of conditions, which I can go into a little bit later on. But in developing these diagnostic tests, we are reminded of the WHO assured criteria, which I think most people will be familiar with. These have actually recently been reframed, and they're now the reassured criteria, which brings into frame issues such as connectivity, ease of specimen collection, not to mention the specificity, the sensitivity, how user-friendly they are. But also other kinds of discussions that we have to have around this are, what is it socially acceptable, desirable? Have we engaged specific communities? Have we engaged the healthcare workers on the ground? How will these technologies ultimately be used? Issues of affordability, cost, shelf life, storage, all of those help to frame our approaches to research. So these are the challenges that we are, the challenges, I guess, that we are looking at. And while most of these cannot all be addressed in one diagnostic test, I think that there are a range of different solutions that we can look at. Thank you.
Thank you so much. I'm going to just sort of move on and want to talk a little bit more in sort of connecting some of the issues and opportunities that you brought up in terms of the sort of promise that precision health as a model can bring. And before we do that, Stefan, it's often said that health is influenced as much by genetic code as by postcode or the area code of where you actually live. The onset, progression, and recurrence of disease is influenced as much by biological information, environmental and behavioral characteristics, and that social, economic, and cultural context of individuals. I think hence the fantastic social autopsy that Corin was mentioning before, really that holistic take of what it means to be healthy or not healthy, as the case may be. So in addition to what Corin and Janice have already mentioned, what are some of the socioeconomic and cultural context challenges that we need to address to unlock more effective and equitable health service delivery models?
To me, it's much with the enthusiasm that all these genetic tools bring. I sort of see a certain risk of us falling into genetic determinism. But then a lot of these things, as you alluded to, and the previous speakers here, we've already known for a long time. And I think we know pretty well how to take age and sex into account when we think about different things in health services, be they preventive or curative. But socioeconomics, who's poor, who's educated, who's not, I think there's a whole sort of course, science tradition to study the effects of it, but how to actually deal with it, we've been much worse. So that's sort of saying in who you are. But the idea about the postcode is also about where you live. When I was chief of health for UNICEF, we actually started looking at where our strategies were applied to, and that was uniformly to rural areas. But meanwhile, the world is now 55% urbanized, and we'll soon be 70% urbanized, and we have 1 billion people living in slums. And obviously, if you're living in an informal settlement, high density in a huge city, that's a very different thing from living in a rural village. And so what do we do to take that into account? And then obviously yourself, are you poor, are you rich, and all of that bit. And this applies not just in poor countries, even famously in Sweden, where I'm based now. We have at least 2 cities where the different ends of the subway line from one end to the other has a life expectancy difference of 7 years. So I think unless we become deliberate about who you are, also socioeconomically, where you live, and potentially also which condition you suffer from, whether there's stigma attached to care seeking or not, then I think we'll remain at a loss, and the genetic tests will not make any difference.
Well, thank you, Stefan. And I thought it would be helpful just to do a quick sort of reminder to everyone of what sorts of technologies, because you've heard about them. You've heard a little bit about, you've just mentioned genetics. Janice, you spoke about diagnostics. So really, when we're talking about precision health technologies and innovations, these can be novel biosensors, next generation wearables, genetic therapy, just as Stefan was referring to, genomic surveillance, the one that we are somewhat all familiar with because of its application during the pandemic, and that is RNA and mRNA therapies, or as the case was, actually applying those to diagnostics. And then really all these applications around genomics for precision health. And if you want to dive into what does that all mean, and what does it practically manifest itself to be, please do take a look at the report that's been linked in the chat to everyone. And again, just to sort of bring some thoughts practically together that we've had in this first session, precision medicine for children and adolescents can really address some of these incredibly high childhood mortality causes. As Karen mentioned, malaria, diarrheal disease, tuberculosis, pneumonia, HIV/AIDS, and other health-affecting conditions and diseases such as asthma, childhood cancer, sickle cell diseases, rare diseases, and even up to and including mental health. So again, if you want to look at some of those applications, you'll find that report will really unpack those. But as all of our panelists have emphasized, your ability, our individual ability to access these, the context in our social and kind of really holistic context is incredibly important. And we're going to deep dive into precision health and how it enables early detection and accurate diagnosis, because as Karen really neatly outlined, having enough time to understand your health condition to be able to access then the right kinds of treatment, support, care, and expertise is the difference often between life and death. And there are so many, really of those social contexts and environmental contexts that can aid or hinder an individual's ability to access that. So what does it mean when we are applying precision health to integrate a multitude of clinical and other data, to optimize treatments, to improve things like dosage, to reduce side effects, and to accelerate the development of new drugs and therapies by understanding underlying health and disease mechanics? The onset, progression, and recurrence of disease is influenced by these biological information, but as you've just heard, a number of other holistic contexts and factors. And so while precision health does hold great promise for children and adolescents, let's turn to some of those specific application areas and understand not only how they might deliver better health outcomes, but what are some of those challenges. And just to sort of share, when the team at UNICEF in the Innovation Nodes was going through the process of finalizing this report, we had a really fantastic debate around, what does this mean? Because why do we call it precision medicine? And why would we call this precision health? And we took a very intentional and deliberate decision to focus on calling this precision health, because we wanted to really advocate and unpack and, for example, like this connected conversation, explore exactly this. What does it take to understand and overcome some of those challenges that sort of move some of this from science fiction to actual living facts and an actual treatment, diagnosis, etc. So speaking of diagnosis, Janice, you and your team have been at the forefront in the world of leading research in innovative solutions for diagnostics, which seems to really be a great place to start this conversation. So could you share with us some of the most promising applications of precision health in this domain? Really recognizing, once you recognize the research lab that you lead has a keen focus on sort of the needs of women and children in marginalized communities in developing countries and emerging economies specifically. So over to you.
Thank you, Tanya. So when we think about developing diagnostic tests, we obviously need to consider how they'll be used and the environment they will be used in. So considering access as a key issue, delivering diagnostic tests that can work remotely, that can have a long shelf life, are cost effective, can withstand fluctuations in temperature, and do not suffer from batch to batch variation in terms of their generation, is quite important. And several years ago, we started working on molecules known as aptamers. And these are really to look at replacing, or at least working alongside, antibodies. So most of our diagnostic tests on the market utilize antibodies. Antibodies work quite well, but in terms of shelf life and storage, there are some limitations, given their susceptibility to temperature, humidity, etc. And so we started working with aptamers, which are really short chains of oligonucleotides, so single-stranded DNA. And what was attractive about this is that they were quite resistant to those physicochemical fluctuations. And more importantly, once we generated them, they were a fraction of the cost of antibodies. And so with this longer shelf life, we started exploring this. And furthermore, I should also mention that we can generate aptamers to a wider range of targets than antibodies. So this was really exciting for us. And we started exploring specifically how we could use that within fetal and maternal healthcare. We started looking at HCG, which is the target, or beta HCG, which is the target of most pregnancy tests. And we were quite surprised to learn that a lot of these tests that rely on antibodies that might not necessarily target all the different variants of HCG. And that would limit, or at least results in some inaccuracies in the results, but it also potentially limits its application for monitoring maternal risks or during pregnancy. So we also realized that HCG could be monitored and also serve as an indicator or a red flag for some fetal abnormalities or high-risk pregnancies. In any case, having access to these kinds of diagnostic tests would allow for pregnant women to access care in advance, and would certainly help healthcare providers in making decisions much sooner. So we started working with the aptamers, and we generated some successful aptamers, we believe, that can target a unique epitope on beta HCG, which should allow us to be able to detect all the different variants. So I think that we will move that along in terms of getting better accuracy. We've also been working on aptamers that can target malaria as well, which is quite an important issue. So looking not just at aptamers which can target, which can tell us whether somebody has malaria or not, but potentially to help identify whether it is Plasmodium falciparum or Plasmodium vivax, because that will obviously inform the treatment strategy followed. So our research is moving quite fundamentally in this direction, is towards focused diagnostic tests that can withstand the different storage conditions, and hopefully result in diagnostic tests that will be more accessible and usable as well.
Fantastic. Thank you, Janice. And I mean, just to sort of, bring that to life, I think, Corin, as you'd mentioned, people live and are trying to operate, especially our frontline health workers, under really difficult conditions. So, this is not, as you're sort of saying, Janice, the pregnancy test where, you wander into your nearest pharmacy, you pay for the pregnancy test, which has been stored and transported under these ideal circumstances on a clean and dust-free shelf, and off you go and find out, whether you are or not pregnant. These are, people, which even though we're more than 50% urbanized, that rural and even urban, environment where the cost of something like a pregnancy test still today can equate to days of income. So, are you going to spend that money to get that result or not? Probably not. If you're really far away, those tests that are based on the current, primarily the current technologies used, antibodies, are not going to be very accurate. And they're not, because if they move off being stored under, temperatures that are very high, where there's lots of fluctuation, where those conditions of storage are really less than ideal. You can amplify that for every other test. So the affordability and the accessibility, Janice, as you're talking about, is absolutely critical. And as you mentioned, being able to have a malaria test that can tell you not only do you have malaria, but which type of malaria do you have in an area where there are two different types co-occurring, which unfortunately, due to climate change, is now an even bigger and bigger geographic area. That's critically important, because not only is malaria a childhood killer in and of itself, if you're somebody, especially a child, who gets the medicine for type A, and in fact, it turns out that you have type B, that's actually a problem, because for however many days you're on the wrong treatment, you are not actually getting better. And we're still, that is a condition that really contributes to treatment-resistant sort of strains of malaria. So again, practically, we're talking about saving lives, getting things to, in that diagnostic stage faster, but it actually benefits all of us. So even if you think you're very far away from that child, we're actually, not. And speaking of treatment, Stefan, you mentioned earlier the use of precision health for identifying or diagnosing at-risk groups will only yield a health dividend if it's appropriate and precise actions follow. So exactly this point, it's, diagnosis is but one in a whole chain of things that need to be in place for health equity to be realized. So how might precision health drive improvements in the treatment of different diseases, particularly in these low resource settings, such as those, as where UNICEF, its partners, work, and where you did much of your work and do?
Well, when you're in that health center, certainly it's nice to know whether the febrile child in front of you has malaria, yes or no, but there's any other number of conditions that can cause fever in the kid. And if you're that frontline health worker, you need to guide your actions. And saying, and I think when the rapid diagnostic test came for malaria, it was fantastic, because suddenly not all febrile children were considered as having malaria. We could even start thinking about pneumonia, which was revolutionary. But the management action that needs to be guided for the health worker is certainly malaria, yes or no. That's a big help. But then once you say, oh, it's not malaria, then what do I do? And one of the chief questions is, do I give this child an antibiotic, yes or no? And that's a very an action where I think we're quite far too liberal still. We're dishing out antibiotics, and we're finishing the effective antibiotics due to resistance. And as we've learned, even getting an antibiotic when you don't need one is not necessarily harmless. It could even be bad for you. So to me, if we can also have a diagnostic strategy in these precision technologies where we think about guiding the contextualized action. Does this child need a malaria drug, yes or no? Would this kid benefit from an antibiotic, yes or no? Should this kid have an antipyretic, yes or no? Should I send this kid on for referral, yes or no? That's the kind of precision in actions we need, because it's those actions that will ultimately determine the outcome. And similarly, I think the febrile child, and I'm still waiting for Janice to give me the fever test that the frontline health worker can have, which says do this ABC to inform some of these IMCI thing guidelines, etc. But I'm also waiting for Karin to actually give me, to you, not just to put the algorithm of IMCI or ICCM as a dumb paper algorithm inside a phone, but rather use the fact that you're holding a computer, which can say, oh, it's this age and it's this context and it's this number of days with the fever, plus Janice's test says this. That that's a lot of conditional probabilities that we can actually guide the health worker in taking action. So if we stay with the febrile child, there's a number of actions we can take, but also in other areas. I think we've spent years predicting risk in pregnancy. Tanya, you have a risky pregnancy. Please go make sure you deliver in a hospital. But I never give you a voucher to make sure that you make it to that hospital, right? So which are the women we should really concentrate the referral action on, etc. So predicting risk is fine, but actually precision in action is even better, because we have scarce resources. So we have to make sure that we do the right actions, whether that is sort of who we send to hospital, how we use antibiotic efficacy and not waste it, etc. And ultimately, of course, benefiting the patient, the individual febrile child. So if we think one step ahead, not just one pathogen at a time, but one contextualized management situation and the kind of decisions that need to be taken, that's where we need to move, I think.
I love how you've shifted this conversation forward, Stefan, as well as thrown down a number of juicy challenges to all of us, because I think having a better problem or a better challenge is a sign of progress. It's also a sign of the more progress that needs to happen. And, you know, to take that step of, as you're saying, that let's not just look at episodic things, but let's actually take a holistic and longitudinal approach. Karin, I want to turn to you around, you know, really not even only that, but actually even maybe one step further back, or you know, one level further up around what could this mean when we apply the thinking to prevention and health promotion? So how might health systems shift as a result of applying precision health innovations to, you know, something bigger and not just as episodic treatments? How do we think about that promise of precision health innovation in driving prevention and health promotion, which would actually, you know, in some cases stop us having, you know, the disease that is giving that child a fever in the first place?
Yeah, and I mean, I think Stefan has alluded to it, you know, in the ideal world, we would like to know all the risk factors that our children have. As a caregiver, I would obviously love to know both the genetic predispositions and all her exposure to risks, and be able to sort of have a clear picture of what I should be looking out for as a parent in the future. And also to know that my healthcare provider has this information and can track my child over time and monitor her health risks regularly to ensure that she stays healthy and she gets the right treatment when she's sick, the right diagnosis, and guidance to me as a parent on what I can do at home to prevent illness like that. It was obviously what we all would dream about. I mean, digital health and longitudinal child health records can only take us so far. I mean, yes, we can program them with algorithms, and we can, if countries allow the data to be in the cloud, which is a big hurdle at the moment, that many countries don't feel safe putting patients' data in the cloud, and therefore it's not always possible to do this big data analytics and AI solutions applied to patient information. But should we have that in place, of course, some of these diagnostics and predictive diagnostics can be applied to a longitudinal child health record, and it can also improve our understanding and management of children's health risks, because we know where they live and where they are, their previous illness history, and sort of that medical attention can be tailored based on the individual's child's history. However, today, I mean, the digital platforms are there they exist, and they're ready to be implemented and scaled for that purpose. However, these are costly symptoms. They don't, you know, you don't deploy those in any context in a short period of time. They are extremely expensive. And we know from countries who have tried to implement them, even just for immunization and to track children's immunization records over time, we're talking tens of millions of dollars. So while the systems are there, some countries are starting to implement them for longitudinal and comprehensive childcare. Very many countries are not there yet, and don't have that maturity and not the finances to be able to, it's a prioritization question, right? Of where do you put your limited health budget? Do you put it into the diagnostics and the treatments, or do you put it into the digital platform and the training of health workers and the hardware and connectivity needed for these systems to be fully functional? So it's, of course, a dream solution, but I still think we're quite far away from having these types of systems implemented at scale. But one thing I wanted to also flag that is doable today, and it comes back a little bit to Stefan's point around postcodes and understanding risks. And this is that we are already playing and trying out solutions. We are actually working in 5 countries in West and Central Africa at the moment, where we are trying to instead diagnose the risk of communities rather than the individuals per se. And we use innovative technologies like satellite imagery and AI tools to analyze satellite imagery to get a better understanding of where people live, where are the households and the settlements and their geographic distribution. Because remember, many of these countries have not had an updated census for maybe 10 years. So we don't even know the number of children who live in these villages. And we don't know, sort of, many get unregistered and they die even before they end up in a birth registration. So what we're trying to do is to improve through these data science technique and satellite imagery with AI is to improve the granular population estimates at community level. And then by adding data science on top of that, using survey data, we can actually estimate which households are likely to have lower socioeconomic status using a range of indicators like distance to roads and sort of the location and the postcode of the household, but also indicators such as from survey data on number of children who are not immunized. We know the number of children who are 0 dose are actually increasing in the world. And by having survey data, we can use regression models to actually put all this data together and identify households at risk and communities at risk, and better than target outreach and target interventions better to the households who need it the most. And having a sort of an under-immunized child is often a proxy determinant for also having other social deprivations in that household. So we can better tailor the response to these communities that may need more attention. And it could even include things like where to put the next health facility or where to train more community health workers and deploy them to provide services. So I think that we need to look at all these types of diagnostics, both for the individual, but also for the society, especially where the data is and lack of data is an issue.
Thank you so much, Corin. And I want to flag that I think you've also in that response answered one of the questions that was asked in the chat. And I want to use that opportunity to encourage others. If you have other questions, please add them in the Q&A, and we will definitely hope to get to them. And that question specifically was around whether we consider, or where do we consider AI, data science, etc., machine learning as part of this really constellation of precision health. And Corin, I think that what you did as well is really neatly make a connection that I want to highlight to something Stefan mentioned earlier, which was when we were talking about pregnancy, and he was sort of saying, well, if you're somebody who then needs that follow-on action and needs a voucher, what does that mean? And that voucher is around a transportation. So if we know you're already in a geographic location that is X far away from where is the nearest health facility that would actually have the sorts of expertise, training, equipment, and let's not only mention, power supply, etc. All of those infrastructural needs. That's that simple thing about, being able to inform the action, but, at scale is really that great promise when we have many connected pieces together. And I think that's the complexity of this. So let's just turn towards much more around that equity in horizons for precision health innovation and what it means, to impact the lives of people. So when the design and development of precision health technologies are linked with the Sustainable Development Goals, these potential multiplier effects, this kind of effect and impact at scale, the impact that research such as Janice leads in real lives can be realized and can drive and address greater health equity. However, because there is a however, of course, to move towards accessible precision health, really does require reflection on how to revise the business models and the incentives. And that actually is this whole idea of business models is something that the work at the nodes for the next sort of 2 years is really very focused on as well. So, what do we mean by this? It is around, preventing precision health innovations from favoring only a small group, because it is easy to imagine when, for those of us who sort of see some of these advances that are really, the healthcare, just for me, my wearable that is collecting data and my smart toilet that is taking diagnostics every time I use it and feeding that back into a system, and I'm kind of getting precision, individualized, gut biome therapy. That seems out of the reach for most of us on this panel. Never mind the millions of people that we're trying to really focus on in our collective work. So how do we prevent that kind of amazing technology and solution from only favoring the very wealthy or the very connected or the very well health insured? How do we support and sustain that really long journey from discovery, science, that kind of research piece through that long development phase to when things actually become accessible to people, real people? And how do we enhance strategies to advance health equity and sustainable health outcomes? And finally, explore alternative healthcare production, delivery models, this entire discussion in the development sector around localization, amongst other strategies. So I'd love to draw on the panel, and maybe Janice, turn to you first, and ask, a long-running focus of your work and something that your team at Rubik is demonstrating in practice is the critical importance of equity from the very outset. So what do we even research? Who even sees some of the problems? To Stefan's challenge, who's giving me the fever test? Because, the technology exists, the expertise exists in the world, but not everybody sees that as something that is important to study. Not everyone understands, the need for research in those kinds of areas, for example, for those sorts of diagnostics. So it's really important who is doing the research, where are they, and that equity from that very outset. What lessons can we draw from the work, Janice, that you and your team have been doing to inform a more equitable approach to research and development in this domain? Over to you.
Okay, so Tanya, my research is really framed by South Africa's engaged research strategy. And at the moment, I'm the South African Research Chair in Biotechnology Innovation and Engagement. And what that means is that we are studying how best to engage with communities upfront and throughout the whole value chain, or the whole pipeline of research, from identifying the issues all the way through to product development. And of course, that's quite a lot to do within higher education research. But it's really shaped the research, and recently it's also started to shape the innovation work as well. So our students have started engaging at multiple stages, right from the beginning, at the prototype stage, and we have some students moving closer to final products. There's a lot of talk about co-creation, bringing communities on board. And what does that really look like in practice? What does it look like in practice to have longer term engagements with communities? And what are the outcomes? What are the goals? And our research has shown, or at least we've seen, that engaging communities in research definitely can shape the direction of the research, that localized perspectives and people's experience and their knowledge can shape what we do in the laboratory. And so our research has engaged communities as partners in the whole process. And so this is obviously made possible by the specific research that I have and my research chair, which is why I mentioned that, because it is not possible for all researchers to be engaged as engaged as we are with communities. However, I think it's something that we should be striving towards. And I've certainly seen most of the research grants or calls ask us to reflect on the communities. Who are the people we are researching for? Who are the communities who will benefit from this? And we've also been asked, who are the community partners that can partner with you to take this forward? And then finally, is there a specific industry that can help support the product development stages? So, and I think this is quite insightful. We have scarce resources for research as it is in South Africa and in other countries as well. And so prioritizing the work so that it benefits specific communities is one approach that we can follow. Some other lessons that we've learned is that our students, and I think this is quite important, is that our student training, engaging communities, changes their perspective of the research that they can do. So changing from a student doing research for a degree, it is shifted towards doing research that can have a positive outcome for communities. And we've certainly seen that this has shaped students' motivations for research. And I hope that in the longer term, it also assists them to be able to tackle the grand challenges of our time. And I think that engaging multiple stakeholders in our research and certainly the communities is a specific approach and helps to shift us towards transdisciplinarity in higher education and in our research. One challenge that we have had is that engaging communities does raise the prospect of solutions coming soon. And we understand that the research environment can take quite a long time, especially in higher education where students are coming for short periods of time and leaving. And we recently decided to explore whether we could offer water testing to communities, for example. So there's a strong need for potable water and for communities to know the quality of their water. So we unlocked this opportunity by opening up our laboratories, providing access to communities who could then bring their water in and have that tested. And while this supports our research, it also supported establishing longer-term engagements with communities, and it helped to bridge the gap between the research and a product in the future. And it also has helped us to look at how we can better co-curate and really help bring that into reality, because the word co-creation is bandied about quite a lot. I think it's a process, and we certainly have to try and move towards that. But the other benefit of this has also been that it has advanced literacy around science and water treatment and people's understanding of the quality of their water. It's enabled agency, and we've certainly seen advocacy as well around water quality. So this has been, these are some of the lessons we've learned.
Thank you.
And yeah.
Thank you very much. And I'm so glad, that you mentioned transdisciplinarity, because I think that is not only, in its broadest sense, around and the language around co-production, collaboration, and co-design, etc. It really does have that meaningful engagement component. And I'd point to your lesson learned also highlights a different challenge for a number of, both private sector and other academic institutions around. They're very far away from the place where research can have the kind of impact, with communities that you have. So you have this fantastic geographic access. But I think one way for academic institutions and other R&D entities to think about, how they understand the kind of communities and impact their research can have is to look for and partner with, as I know, Stefan, you might mention later, Karolinska Makerere in Uganda. I know, Janice, you just recently hosted a group sort of on a session from Australia. That really, this is where we see that recognition of the value of the institutions that we can sort of say in emerging economies, or if we use the language, the global south. These are places that, in their fluency and their deep understanding of the context of these challenges and their trust, as you pointed out, Janice, with communities. That isn't something you fly in and, administer a survey and you're done. It really is a long sort of process. So just thrilled that you brought those issues up. I also wanted to mention that when I come to your lab and look around, who is doing the research is a critical component, and I don't want to miss that, because it is researchers from across the continent. So it's really become this kind of point of gravity for research in biotech, and I know there's a nanotech, a really well acknowledged nanotech lab there as well. It's from across Africa, and also just to acknowledge there's a gendered component, in science and research as well, but you have an incredible array of young female scientists as well. And I think that's something, we've highlighted. And for anyone, point of interest, if you go to the UNICEF website and you look at some of the images that we use to illustrate what it looks like in terms of who is doing research and what does this place look like, those are images that are actually taken from Janice's lab and feature, real life researchers doing the work that she has just been talking about. But let me turn to Corin. Much of your work as the lead in digital health for UNICEF has involved devising tactics to ensure equitable access to those emerging solutions. So what lessons can we draw from your work to inform a similar pursuit of equity in precision health?
Yeah, thanks, Tanya. And I actually think there are many areas where I see synergies between the learnings from our digital health work, and that could be applied to precision health work. And I can think of 5 specific areas, some which have been addressed already. The first one being around leveraging data for informed decision making. I mentioned this example of how we can use digital health initiatives to harness data and analytics and geospatial information and AI to really to pinpoint the underserved communities and tailor interventions. I think this is an approach that is equally crucial in precision health, and where data-driven insights can guide personalized treatments. So obviously, taking that data-informed approach is definitely something we can learn from and see cross-learning. Another area, which is a little bit broader, is around strengthening the health systems in which these solutions operate. And our work in digital health we've seen it really underscores the necessity of a robust health system. We cannot fix a broken health system by throwing in digital solutions. It just means you get a broken digital health solution. So what that means is that we really need to also invest in infrastructure, connectivity, for example, training of the health workforce, and fostering that community engagement that we discussed already. And what we see here as well is that it's incredibly important to invest and strengthen the capacity of especially the female health workforce. We know women make up more than 70% of the health workforce, but there is a digital divide. There's a gender gap in access to digital technologies and also digital literacy, which is required to be able to operate in this space. And I believe that even for precision health, if we want to make similar investments, we need to build that capacity of the health system and the health workers within the health systems who will be delivering this personalized care and so that they can use it effectively and equitably. Another area which is also becoming very important, we can see more and more important, is to address the social determinants of health. We've seen reports now showing that connectivity, for example, is becoming a super determinant for health, meaning that it underpins so many other health areas other areas outside of health. For example, if you don't have connectivity in a more developed society, you cannot really apply for housing, you can't apply for benefits, you can't apply for schools. And if you are left outside of that, being homeless on the street or suffering from other deprivations because you cannot access the system or participate in a digital system, that has severe health consequences, and especially for children growing up in families with no connectivity can be very disability. So I think taking this approach also for precision health is critical to look at how there's a link between health and education, economic stability, and social support, etc. And taking that multi-sectoral sort of integrated lens when we look at personalized care plans is going to be important.
And I want to jump, there's a point that you mentioned about multi-sectorality that really makes me want to jump in and ask Stefan, but sorry, please finish.
Yeah, I just had maybe one more area is, which I think is critical to learn from is who is going to pay and how will this be paid for. We know we have a large number of very well performing digital health solutions out there, but we have finite health budgets, and somehow implementing these systems will need to take money from somewhere. And what we need to be able to show is the sort of the savings, potential cost savings of having these more advanced techniques and solutions in place. And that goes for precision health as well. We know that diagnostics can help save medicines, can help improve the treatment outcome, but it doesn't save money necessarily, because it is cheaper to just dish out antibiotics. And we've seen this from when we try to work with some people online, I see here as well, who've worked on trying to improve the pneumonia diagnostics, for example. And we had some tools that were actually not bad in improving pneumonia diagnosis in children, but no country was willing to pay for them because it's too expensive to invest in a diagnostic device when it's still cheap to give out antibiotics. So I think that's another area we haven't definitely not solved yet.
No, and I think as you point out, it's, you know, it's not as easy as yes, no, and then the next action. It's really this whole health system approach and beyond the health system. And I know, Stefan, that is something that you have recently been advocating for. So, you know, a whole life course approach, a whole multi-sectoral approach, and really recognizing the system is very complicated. And unfortunately, if we come to Corin's point about, you know, how would we talk about the total cost of things, that gets quite complicated and longitudinal as well to talk about. So when we, you know, consider how might we realize the potential of precision health, particularly in low and middle income countries, which is sort of almost back to where we started, health service delivery, national health system strengthening, what might such an approach look like, and how could it contribute to more equitable advances in precision health, and most importantly, really in the health of children and women?
Well, you know, to me, the whole issue here is to think about and distinguishing health from healthcare. Because health actually, when I came to the Uganda Ministry of Health once in a blue moon, the Director General, Professor Omaswa, said, health is made at home, hospitals are for repairs. And then most of us who have gone to medical school, when we say health, we mean healthcare. But the real determinants of health, I mean, if we think about infectious diseases, your quality of housing will determine your risk for malaria and pneumonia, whether you're next to a swamp, whether you have toilets, the wash issues will determine all of those issues. And whether you go to school and whether your mother went to school is a supra determinant, isn't it? So we need to go to other sectors and we need to engage all of these. And I think that's true for infectious diseases, but it's even more true, I would say, for the so-called non-communicable diseases, where 1/3 of the world is now overweight, and this starts in childhood. And that's driven by unhealthy food environments, unhealthy physical environments in the urban cities and wherever we're living, and unhealthy social environments. So the right choices need to be made, the easy choices, but to the point of this call, also the affordable choices. I mean, there's not a mother in Africa who cannot tell you what it would be nice to feed their kids, right? The question is, can they afford it? And what does affordable protein look like? Is that a hen's egg still, or is it something else? But then also speaking to the urban environment, what does good quality housing look like? What does city planning look like that makes it possible and safe and desirable to walk, etc.? What does that architecture look like that will make me take the stairs rather than the elevator, etc.? And that's the multi-sectoral approach. Sweden now has a diabetes type 2 prevalence of about 5%. Uganda, which is my host country where I live, has 10%, and India has 20%. So, and a lot of that starts in childhood. So it is life course, it is multi-sectoral, and I think we need to sort of get out of our health centers. It's nice to have healthcare when you're sick, but if we're really talking about health, it requires us to think ahead. But to Corin's point, building those longitudinal systems, I think we also need to be humble and say, why are we building separate health systems digitally, longitudinally, because birth registration people need it, the education people need it, the social service people need it. I mean, a country like Estonia, admittedly at another economic level, they've built a multi-purpose system. And I don't know how many places I've been to where some brave UNICEF person has proudly demonstrated the birth registration system that doesn't work typically. Then we go looking for zero-dose children in the health services, and then the education set up their own thing. Why don't we register pregnancies? Because most countries have more than 90% antenatal care attendance, and then we have the beginning of tracing your life longitudinally, certainly with all sorts of technical issues and caveats and cost issues, etc. But let's step out of our healthcare kingdom to actually be humble and realize the determinants of health, and that the solutions will span across all of these sectors, including building a digital system for multiple sectors and thus also having multiple payers. Thank you.
Thank you, Stefan. And I think you've kind of landed us, and in the process, that really talked a little bit to one of the questions that we had, which was around, healthcare data. So, I mean, absolutely, it's not even healthcare data, but really sort of data and all the questions around privacy and access and applicability and use, etc. That will all raises. And I think, Stefan, what you've also challenged us to is something which recognizes that not only is when you step back and back and back, or to that 50,000-foot view, it is around an extreme amount of complexity and things that are moving in real time, really quickly. And I think that ties back so nicely to what Janice was mentioning about why it's important, therefore, to have this transdisciplinarity and a transdisciplinary approach, because being siloed in whatever way you apply your silos, whether it is institutionally that you just mentioned as a way of helping to organize work, or it is actually in terms of how health ministries and other ministries and governments organize themselves, or how we sort of think about health in a bucket separate to everything else. It really becomes that much more relevant, and makes me happy, because transdisciplinarity is one of the key themes that we try to take as an approach to the Innovation Node work. And to bring that back, I would love to ask you each one last question, which is, reflecting on this wonderful conversation that we've had and really benefited from all of your expertise. Thank you. What is one domain of uncertainty that now you're inspired to examine in more detail as a result of this conversation? So I'm going to throw it to Janice, and then Karen, and then Stefan. What is, one area of the unknown that you'd love to illuminate coming out of today's connected conversation?
Thank you, Tanya. One challenge that we have is that we're becoming quite good at getting a localized perspective about specific challenges. But if I look across the landscape, I think there are definitely commonalities across countries and common challenges that could be addressed through transdisciplinary approaches and collaborations. I'd be very interested to continue discussions around this, and certainly our work with UNICEF has helped us to get a broader view of the challenges on the ground in multiple countries. And I think that UNICEF Innovation is well placed to lead some very exciting new areas, new grand challenges that we can explore. And I think that having the access to such a transdisciplinary team and bringing in stakeholders from elsewhere would be a way forward.
Thank you so much. On to you, Karen.
Yeah, I keep coming back to this thing that keeps me up at night a little bit, is around costs and who will pay. And I'm still thinking, I'm just thinking a bit more now after this conversation that it would be, we haven't done enough economic analysis of neither of the digital health or longitudinal care sort of innovations, interventions, but now even adding sort of more precision diagnostics, even if it's done through algorithms and AI. I think if we want to do that over the life course, we should do some more serious sort of cost-benefit analysis to really understand not just the, because we often look at the costs needed to implement, but we're not really that good at looking at the consequences of where possible cost savings can be made. If we have more targeted health interventions, we can maybe drop a few blanket campaigns, which we know are super expensive and not very effective if it doesn't target the right population. And I think that's an area where I would really like to see some more work and thinking.
That's terrific. Thank you, Karin. And the last insight from you, Stefan.
I think building on what Karin just said, I think thinking about what is a health promoting community in terms of multi-sector to promote health. I mean, we do measure multidimensional poverty now, but how about turning it around and actually saying, okay, what's the community diagnosis here from a multiple health and social determinants perspective, and then focusing and contextualizing efforts accordingly. To me, that's exciting. And in fact, I've started hanging out with architects and city planners and food systems people now. I mean, you learn stuff. It's exciting. I can recommend it.
Fantastic, Stefan. Thank you. Thank you all again, and to everyone who's joined us. And really, are so pleased to have dived into that health equity component of precision health. I also want to flag up that actually the thing that keeps Karin up at night around the business model, around the financing, who pays, who could pay, how could we deliver this from a business sort of model aspect, is going to be the focus of our next connected conversation, which will actually bring some of us together in person. Thank you to the hosting of Karolinska Institutet on the 19th of August. This year. So we will make sure to be recording that and to be sort of sharing that as well. So please, if you're interested, keep watching this space. And again, a hearty thanks to Professor Janice Limson, Professor Stefan Pettersson, and Dr. Karin Cullender for joining us today. Thank you all until our next Innovation Node Connected Conversation. Bye-bye.